Hello, once again, my name is Mr. Chitumba. In this presentation, I'm going to discuss about the pancreatic pseudocyst, and then I'm going to give you a model or sample report on how you report this type of a pathology. What we have here is your pancreas. So a pseudocyst can develop anywhere. It can develop in the tail of the pancreas. It can develop in the head of the pancreas. It can develop in the body of the pancreas, just outside like this. So you can see it develops anywhere. So I'm going to discuss on a case of a pancreatic pseudocyst that presented, and then you can visualize or can see how sonographically it appears like. So you can see here, this is the left lobe of the liver, and you can see here we have got a cystic lesion that we have here. The cystic lesion, it has got a little bit of some internal echoes which are just floating like that. You can see it here again. That's the cyst that we have, and then the cyst, we have to differentiate it from a fluid-filled stomach. So how do you do that? You can ask the patient to drink more water. So when they drink more water, you can see the stomach feeling differently or separately. So if you see that this lesion is distinct from the stomach and then is presenting around the pancreas, then you have to suspect a pancreatic pseudocyst. So this lesion was presenting on the head of the pancreas, and you can see how it looks like. So I need us to understand how you report on different pathologies. So below, I am going to give you a sample report on how you report on such a case. So this is a sample ultrasound report for this case that we have here. So abdominal ultrasonography demonstrated the presence of an 11.7 by 8.8 by 10.5 centimeter pancreatic head cyst in projection to the liver. The cyst contains free fluid inside the wall with a thickness of 6.4 millimeters. The cyst is distal acoustic enhancement on ultrasound examination. The pancreatic body tail appear normal. Main pancreatic duct, the duct of Wisang and the accessory duct, the duct of Santorini are normal with no focal dilatations. No intracystic perfusion was noted on ocular Doppler. So this formulates the body of your report. So in this instance, I am just doing organ-specific reporting, of which at times you might need to do the whole abdomen when you are doing the abdominal ultrasound scan. So these are the components that you have to highlight in terms of your report. Report on the dimensions of the lesion that you are seeing in question. Also, describe the lesion. Is it cystic in nature? Is it solid? Is it mixed? Then describe the wall as well. If you can measure the thickness, also measure the thickness. So the posterior wall characteristics of the lesions are also very critical or necessary. So in this case, it's enhancing distally. At the same time, you have to capture the rest of the organ if they are normal. So in our instance, the pancreatic body and tail are normal. So you also have to check if the pancreatic ducts are not dilated. At times when these pancreatic ducts rupture, they are the ones which can also lead to the formation of pancreatic pseudocyst. So the last thing that you're supposed to do is the comment or the impression. So when you're writing a comment, make sure by any means try to avoid prescriptive reporting or diagnosis where you just say this is. That can be dangerous in case of litigation. Make sure that you hide from making a very straightforward diagnosis like this. Findings are highly suggestive of a pancreatic head pseudocyst. So you see, I am not 100% saying that it's a pancreatic pseudocyst, but I am saying that findings are suggestive of. So, meaning to say, it can be anything else. So, in the event of litigation, it means I have tried to avoid the wedding that can come back in future and then hit me. So this is how you are supposed to craft your reports. Findings are suggestive of, features are suggestive of. Do not just say this is a pancreatic head pseudocyst. What if it is something else? What if it is the duplication of the stomach or enteric duplication? What if it is something else like maybe choledochocyst? So just be careful with the wording when you are writing your report. At the same time, intralesional perfusion is also critical when you are writing your report. Comment on that if there's a intralesional perfusion or if there's none. So I am briefly here just describing what a pancreatic pseudocyst is and what gives rise to pancreatic pseudocyst. So pancreatic pseudocyst is a fluid-filled sac formed in the abdomen containing pancreatic enzymes and necrotic tissue surrounded by non-epithelialized walls of fibrous tissue. Pseudocyst formation occurs from pancreatic ductal system disruption. It can occur due to pancreatitis, or it can be as a sequel to a trauma, resulting in a fluid and enzyme accumulation. Overall, the prevalence of pancreatic pseudocyst ranges from 0.5 to 1 per 100,000 adults per year. So you can see it's fairly not a common diagnosis. But times and again, in your department, you are going to come across a case of a pancreatic pseudocyst, and you must be in a position to be able to make a diagnosis of this important finding. So, clinical presentation of a pancreatic pseudocyst can include nausea, vomiting, and abdominal pain. So, these are some of the things that the referring clinician can capture in their report of the history. So if you relate at times your findings to the history, your diagnosis will not be much invariant with the clinical findings. So it's very pertinent if you know how to report on anything that you come across. It doesn't carry any meaning when you see something on ultrasound and you are not in a position to report it, because you can actually create non-existent pathologies, or you can miss critical pathologies that can be life-threatening to a patient. So I feel that we must make an effort to upscale our report writing skills and make sure by any means we become competent enough in writing reports that carries a meaning to the referring clinician. So at times too much jargon might not be necessary in your report because it might not give any meaning to the referring clinician. So your language must be understood by the referring clinician so that they know exactly what you're trying to communicate. I believe this is making sense. We will continue on these case reports and also give you the ideal reports on how you write them. I thank you so much for your time. I appreciate your patience. If you've got any question, feel free to type under the comment section. Any additions, you can also type under the comment section. Thank you very much. Let's meet again in our next case presentation.